Welcome back. We are on chapter 21 and we will be discussing resuscitation. Topics of discussion are going to be the pathophysiology of cardiac arrest, patient assessment, and improving cardiac arrest survival. In this first section, we're going to talk about the pathophysiology of cardiac arrest. So the function of the heart is to pump the blood. So it has electrical functions and mechanical functions that must work together. So the electrical stimulation actually causes the muscles to contract, and then pumping muscle requires that oxygenated blood. So without that oxygenated blood, that's when the pumping fails. So what's mechanical failure of the heart? It is the loss of normal heart muscle structure. That's when they cause myocardial infarction, chronic hypertension, loss of normal heart valve function, direct trauma, or pulseless electrical activity, which indicates a mechanical failure. And you'll hear this often as a PEA, so that's pulseless electrical activity. All right, next we're going to talk about the electrical dysfunction of the heart. So although mechanical dysfunction can be the root cause of cardiac arrest, electrical issues are far more common. So under normal circumstances, the individual heart cells move tiny charged electrolyte particles, which are called the ions. They do that in and out of the cell to generate that electrical charge. So this charge cascades from one cell to another to create that electrical movement called the conduction of electrical impulses. So the heart muscle cells are unique in that they can generate their own electrical impulses, but normal electrical conduction of the heart flows through a specialized cardiac conduction pathway. So this pathway sequentially it stimulates the muscles of the atria to contract, followed by stimulating the muscles of the ventricles to then contract. So a microscopic component of the cell called the sodium-potassium pump must be engaged to carry those ions to their designated starting point. So the sodium-potassium pump requires energy to complete its task so that it relies on a constant supply of the oxygenated blood. So when this supply of oxygen is then interrupted or during a myocardial infarction, the ions can't be moved normally, and then the electrical distribution system then fails. So without proper electrical stimulus, the mechanical aspects do not function and blood is then not pumped. So if the electrical system fails completely and no electricity is created, a condition called asystole, or that flat line that we normally see on the monitor, is what happens. So then again, it's demonstrated by that absence of energy. So remember, if you see asystole or that flat line on the cardiac monitor, there is no electrical activity within that heart. So that's where that problem is an electrical versus a non-electrical. So that would be an electrical dysfunction. So more often, you're going to have the disruption of the heart's normal electrical function, which leads to a dysrhythmia. So remember in the chapter Cardiac Emergencies, you learned that ischemia can lead to unusually slow or unusually fast rhythms. So the tachycardic or the bradycardic. So if the electrical disruption is severe enough, it can also lead to dysrhythmias that cause cardiac arrest. Specifically, there's two of them, ventricular tachycardia or VTAC. Remember, that's the one that they can be awake and they can have a pulse and be talking to you. And then ventricular fibrillation, which occurs when that electrical dysfunction causes chaotic and inappropriate electrical distribution throughout the heart. So these dysrhythmias are commonly caused by hypoxic cells responding electrically in an uncoordinated way. So in both dysrhythmias, there is an electrical and a mechanical response, but pumping fails because the responses are chaotic and or they're uncoordinated. So in ventricular tachycardia, both ventricles pump so rapidly that they have no time to fill. So there is no or inadequate blood to pump. So in ventricular fibrillation is a chaotic mechanical response to chaotic electrical activity, which then leads to the quivering motion of the heart that fails to pump any blood. So then the dysrhythmias, like ventricular tachycardia and ventricular fibrillation, leads to sudden cardiac arrest. Okay, so they appear abruptly and are difficult to predict and result in sudden collapse of that patient. So the good news is that the electrical dysfunction of VFib and VTAC is often correctable if it's treated rapidly. So you will learn coming up in these next sections that the automated external defibrillator are used to identify and fix these uncoordinated patterns of the cardiac electrical activity, and then provide you with the best opportunity to reverse these deadly dysrhythmias. So with that AED, that's why it's important when you do see one of these rhythms to get that AED on as soon as possible and get that patient's heart shocked as soon as you can. So sudden cardiac arrest versus asphyxial cardiac arrest. So cardiac arrest is often described as the manner in which the heart stops pumping, either sudden or asphyxial. So sudden cardiac arrest typically refers to an abrupt onset of dysrhythmia like ventricular fibrillation or tachycardia. Sudden dysrhythmias account for more than 85% of all arrest situations, and in most of these dysrhythmias, roughly 89%, are caused by an acute coronary syndrome. So other possible causes of sudden cardiac arrest are congenital heart conditions, illnesses, and even toxins. But even blunt trauma to the anterior chest, such as being struck by a baseball or diving chest first into or onto a hard ground, can actually lead to a sudden cardiac dysrhythmia. So this mechanical or mechanism of the cardiac arrest is known as the commotio cordis. So if you remember the football player, I believe it was last season in the NFL that went down really quick. So like he got hit and then, or he tackled somebody, I can't remember exactly all the details. And then all of a sudden he went down and then went into cardiac arrest. That was commotio cordis. So it was basically when they get hit just at the right spot that all of a sudden they just go into sudden cardiac arrest. Okay. So in sudden cardiac arrest, the most concerning problem is the failure of the heart pump. So oxygen levels in the blood tend to be relatively normal at the beginning of the cardiac arrest period. As far as asphyxial cardiac arrest implies that the heart has stopped pumping due to issues related to systemic hypoxia. So conditions like respiratory problems and shock, which lead to low oxygen levels in the blood, cause this type of cardiac arrest. Systemic hypoxia leads to reduced perfusion of cardiac muscle cells. So without proper oxygenation, an always hungry myocardium becomes ischemic and prone to life-threatening dysrhythmias. So the asphyxial cardiac arrest is typically found in patients with serious illnesses and injuries. So your increased acidity in the blood from the metabolic or respiratory failure is also a common contributor to asphyxial cardiac arrest. So some examples of a patient with asphyxial cardiac arrest are patients with cardiac arrest due to severe asthma and the patient in arrest after decompensating from shock. Another one tends to appear with more warning than does the cardiac arrest. So that asphyxia tends to appear with more warning signs. Both sudden and asphyxial cardiac arrest are treated similarly, but it is important to remember that patients with asphyxial cardiac arrest generally have low oxygen levels and elevated carbon dioxide in their blood. So the quality ventilations are very important for these patients during that CPR. So good, strong breaths are key in the asphyxial ones. Next is agonal respiration. So that is when breathing occurs as a primal reflex during cardiac arrest. It's that small amount of oxygen that allows the medulla to send impulses to the respiratory muscles. And then a down spiral will end in death unless someone intervenes. So that's why it's very important for you to get in there and open that airway, start CPR, and get them breaths as soon as possible. So effects of cardiac arrest. In short, it's the heart fails to pump, the blood stops moving, the cells are then robbed of the essential oxygen and nutrients that they need, the organs are damaged, eventually they fail, and then the organisms will die if uncorrected. The goal is to intervene as soon as possible. Next, we'll talk about pediatric cardiac arrest. So most adult cardiac arrests are sudden and are caused by acute coronary syndrome. Most pediatric cardiac arrests are very different. So in infants and children, only about 20% of cardiac arrests are caused by sudden dysrhythmias, and very few are caused by blockage of the coronary arteries. So in children, cardiac arrests are generally an asphyxial in nature, and they do occur due to prolonged systemic hypoxia, as would be caused by choking, shock, or a respiratory problem. So unlike cardiac arrest in adults, which is typically an unexpected and sudden event, in children, cardiac arrest is generally a predictable outcome after you see a steady decompensation in their health. In this next section, we're going to talk about patient assessment. So during patient assessment, you have perpetual narrowing, which is focusing only on that patient. But you want to use situational awareness as well. You need to make sure you're watching and knowing and understanding everything that's happening around you. So a lot of times what happens is in that stressful situation like these, our own sympathetic nervous system engages in that fight or flight response. So part of that is that our body focuses on what it selects as the most important threat, and that would be the patient in cardiac arrest. That we then tend to forget about everything else that is around us that could potentially cause us danger. So we just want to be sure that we are not focusing just on that patient, that we still keep our situational awareness open and alive, because otherwise that could come into a very dangerous situation. So during the primary assessment, we need to identify the key 3 features of cardiac arrest. The first one is unresponsiveness. Is that patient unresponsive? If so, are they breathing? That's when you're going to go into apnea. Apnea is that absence of breathing or not breathing at all. And then do they have an absence of their pulse? If that is the case, if cardiac arrest is then identified because of these key 3 features, then you want to begin chest compressions immediately. Next is sudden unexpected infant death syndrome. So there's 3 commonly reported types of the SUIDs. The first one is sudden infant death syndrome, or we know it as SIDS. Another one is any unknown cause, and then the last one is accidental suffocation and strangulation in bed. So unless there is rigor mortis setting in, you should be doing everything that you can for that baby. However, if you have to kind of weigh the odds. If the parents are doing CPR when you arrive on scene, are you going to continue with CPR even though you know that rigor mortis has set in, or are you going to wait for the ALS crew to get there and let them talk to them and tell them that there's just nothing more you can do? You're going to know, I mean, the parents are going to need that emotional support, and try to get them to understand that everything possible is being done for their child and so on. Parents who lose a child, though, often suffer intense feelings of guilt from the moment that they find that child. So whether or not the parents express such guilt, just remind them that SIDS occurs to apparently healthy babies who are receiving the best parental care, that it was really nothing that they did. Do not speak, though, with a suspicious tone or ask inappropriate questions. And you don't want to be embarrassed to express your sorrow for their loss. So if you are questioning whether you should resuscitate that baby or not, you always choose resuscitate. Okay? It is better to resuscitate when it isn't necessary than to fail to resuscitate when it is. So if you don't know what rigor mortis is, you've maybe never seen it before or such, then that's when you're going to probably just do it until you have been told or understand what rigor mortis is. They can also have cardiac slowdown and sleep apnea, and eventually will stop breathing and not start again. The episode will be fatal if the infant is not reached in time. And this is typically why people find them, after or during a nap, or, after an evening of sleeping all night long, or, the next morning, I should say, not evening. But that's typically when they find these patients, is after a nap or after they've been sleeping. And I already discussed this, but unless there is rigor mortis, then you're going to provide resuscitation, and again, providing emotional support to the parents or the caregivers. In this section, we're going to talk about improving cardiac arrest survival. So in the chain of survival, there are 5 elements. Number 1 is recognizing and activating the emergency response system. 2, immediately starting high quality CPR. 3 is rapid defibrillation. 4 is basic and advanced EMS. 5 is advanced life support and post-arrest care. Big thing, good teamwork and good coordination. So link 1 is the recognition and activation of the emergency response system. So the efforts that must begin before the arrival of EMS. So that's why we train citizens to recognize cardiac arrest, activate the EMS, and begin resuscitation. You have the dispatcher aided CPR or pre-arrival instructions when they call 911. And then EMTs can participate in public CPR trainings to help train your public and your community on CPR and what to do and when to do it. Link 2 is immediate high quality CPR. So your cardiopulmonary resuscitation that moves blood through the cardiovascular system. So CPR maintains the cerebral and coronary perfusion pressures. Next is link 2, which is immediate high quality CPR. So your hand placement, which needs to be on the lower third of the patient's sternum. Adults, the heel of one hand on the center of the patient's chest and the heel of the other hand on top of the first. In children, it's the same as the adults, but the second hand may not be needed. In infants, with one rescuer, it's a 2-fingered chest compression. And for 2 rescuers, it's the 2-thumb encircling hands. You're going to watch the compression depth. So you want to compress the chest at least 2 inches in adults. Allow for the full recoil on the upstroke of the compressions, spending half of each compression on the downstroke and half on the upstroke. For infants and children, you want to compress 1/3 of the anterior posterior diameter of the chest. Your hands should overlap the interlocked fingers. Elbows should be always locked. The weight of the shoulders should drive the compressions. And the pivot point should be the waist, not the elbows. You want to compress no longer than 2 minutes and switch with another provider. So in this diagram, this is how you should position yourself for the proper CPR form. So again, positioning the upstroke, positioning the downstroke on the hip, and then the fulcrum at the hip, making sure that your arms are always straight, elbows are locked, and then the lower half of the sternum is where you're going to place your hands. Remembering that the compression rate is compressing the chest 100 to 120 times per minute. Compressing too slow does not generate adequate cerebral and coronary perfusion pressure, and compressing too rapidly does not allow for the heart time to refill with blood. So always make sure you're doing nice, consistent chest compressions at a rate of 100 to 120 times per minute. You want to always make sure that you minimize pauses in compressions. So you're going to aim for a compression fraction above 90%. You're going to take the steps to avoid pausing chest compressions and initiate chest compressions immediately upon arrival. Then you're going to clear the rescuers during the analysis phase of the AED. Then you're going to pre-plan the compressor changeout to avoid any delays. Minimize urgency of transport in the initial phase and train as many team in realistic situations. And then train with lots of different tools of resuscitation, from the oral and nasal airways to the nasal cannulas, non-rebreathers, bag valve mask, even including the iGel, King Airways, or whatever advanced airway you may use. Next is rescue breathing. So ventilations should be integrated at a ratio of 2 ventilations for every 30 compressions. In the pediatric patients with 2 rescuers, you want to adjust the ratio to 2 breaths every 15 compressions, or follow your local protocols for ventilations on what your medical director wishes. Next, the mechanical CPR devices. So mechanical devices assist EMTs to provide high quality compressions. Using the Lucas CPR device, you want to stop CPR just long enough to put the Lucas base plate under the patient. Next, apply stabilization strap before moving the patient. And then upon termination of arrest or return of spontaneous circulation, power down. Using the Zoll Auto Pulse, you want to align the patient on the Auto Pulse platform. Next, provide bag mask ventilations at a rate of 2 ventilations for every 30 compressions. After 2 minutes of CPR, you want to assess for shockable rhythms. So link 3 is rapid defibrillation. To achieve successful resuscitation, the heart must begin pumping again. An AED is used to correct life-threatening dysrhythmias. So remember, the AED can only shock 2 rhythms, ventricular tachycardia and ventricular fibrillation. Remember that ventricular tachycardia, they can be awake, have a pulse, and talking to you, whereas ventricular fibrillation, they do not have a pulse and they will not be talking. AED is two devices in one. So it sensors to recognize ventricular fibrillation and ventricular tachycardia. The defibrillator to discharge energy through electrodes and then into the patient. How AEDs work. First, most common conditions resulting in cardiac arrest are shockable rhythms, ventricular fibrillation, and ventricular tachycardia. Here is shown an AED with the pediatric pads. All right, next we'll talk about the types of AEDs. So they are classified by the type of shock delivered. So the first one is a monophasic, which sends a single shock from a negative pad to a positive pad. And then biphasic, which sends a shock in one direction and then the other. So again, knowing and understanding what type of an AED you are using is very important. Next is link 4, basic and advanced life support. Basic life support is the key to cardiac arrest survival, quality compressions, and rapid defibrillation. AEMTs and paramedics provide advanced procedures and medications. First, you have the triangular of life. So one provider delivers the compressions, one provider attaches the AED, and one provider manages the airway and delivers ventilations. Next, the team leader may add advanced life support outside the triangle if additional providers are present. Next is link 5, advanced life support and post-arrest care. Coordinating numerous means of assessment and interventions that together maximize the change of neurologically intact survival. Recognize the return of spontaneous circulation. Heartbeats on its own again and recognized by the patient starting to breathe. Next, you want to initiate immediate transport to appropriate hospital. Manage the airway, blood pressure, and ventilations. Call ALS, have suction ready, and obtain a 12-lead ECG. Next, we're going to talk about the management of cardiac arrest. So first, perform one rescuer CPR and team-based CPR. Next, take standard precautions, use an automated external defibrillator, request ALS when available to continue with the chain of survival, and use a bag valve mask device with oxygen. You want to lift and move the patient, suction their airway, use airway adjuncts if necessary, and interview bystanders and family members. It's always nice to have a coordinated resuscitation team. So you're going to switch roles as compressors to avoid fatigue, so every 2 minutes or sooner if needed. Be sure you have appropriate personnel on hand. Integrate both BLS and ALS care. Facilitate your teamwork, assign a team leader, and coordinate actions using a pre-resuscitation huddle. The steps of resuscitation. Steps ensure that the key elements of cardiac arrest care are provided. Sequence may be different depending on the resource availability. You want to tailor the steps to meet the needs of a situation. Step 1, you want to identify cardiac arrest and begin the resuscitation process. So you're going to identify the cardiac arrest patient. You're going to organize your team, call for appropriate resources, begin chest compressions, and continue without pause as much as possible. Do not move the patient unless it's absolutely necessary. Step 2, you're going to integrate the AED. Deployment of the AED occurs at generally the same time as the chest compressions. One provider should start chest compressions while a second attaches the AED. If responding alone, you want to attach the AED first and then start chest compressions for adults. Begin CPR and then attach the AED for children. In step 2, remember it's the integrate that AED. So you want to begin chest compressions while the other EMT or EMR sets up that AED. Use the AED. Turn it on. Place the pads per manufacturer's recommendations, removing clothing, jewelry, and medication patches. You want to trim excessive hair on the chest, wipe away sweat or other liquids. Stop CPR so the machine has time to analyze, and clear the patient and shock if indicated. If advised by the AED, press the button to deliver a shock. Immediately resume CPR. Immediately begin chest compressions after delivering a shock. Reassess the patient after providing 2 minutes of CPR. Here's the AED cardiac arrest treatment sequence. Again, you want to perform CPR for 2 minutes or 5 cycles unless the patient wakes up, moves, or begins to breathe. At that point, follow your AED prompts. Next is step 3, continue the resuscitation. You want to focus on high-quality teamwork, integrate additional resources as they arrive, and for 2 minutes between the analyzations, you want to perform CPR, offer advanced life support intervention if appropriate, and prepare for next defibrillation. If resources are available, you want to obtain patient information, including the patient history, history of the present illness, secondary assessment, and review physical findings. In some situations, you'll have the family that will watch the resuscitation. Family members may have a better understanding of the efforts made to save their loved ones if they actually watch. So some family members may be unprepared to watch or may get in the way of resuscitation efforts. So you have to work each situation as it comes. Next, we're on to step 4, transitioning resuscitation. If resuscitation is successful, you want to shift to post-cardiac arrest care. You want to focus on rapid, appropriate transport, airway management, and access to ALS. This does include helicopter if you are in a rural area. You're going to check for a pulse every 30 seconds. If no pulse is found, stop the vehicle, start CPR if the AED is not ready, analyze the rhythm, deliver a shock if indicated, and continue with shock separated by 2 minutes of CPR. Terminating resuscitation. Once you start resuscitation, you must continue until either spontaneous circulation occurs, then provide the rescue breathing as needed, or spontaneous circulation and breathing occur, and another trained rescuer can take over for you. You will also turn care of a patient over to a person with higher level of training, or if you're too exhausted to continue. Or you receive the cease resuscitation order from a physician or other authority per local protocols. Next is death notification. If notifying the family of unsuccessful resuscitation, you want to be straightforward and use direct language. You want to allow the family time with the deceased patient when at all possible. You want to take your time and be patient. Do not suggest that you know how they feel. And then be yourself. If this was your family member, how would you want to be treated? And how would you want your family to be treated? Special considerations in resuscitation. First, coordination with others who defibrillate before you arrive. You want to let the operator of the AED complete the shock before you take over care of the patient. You may need to take the first AED to the hospital with the patient so data can be retrieved from the machine. Your protocols will dictate transfer of care. Resuscitation in the ambulance. Initial steps of resuscitation in a moving vehicle should be avoided at all costs. If the patient goes into cardiac arrest during transport, stop the vehicle to perform CPR and deploy the AED. Remember this here statement because what's going to happen is you're going to go to take your test or a test and this may come up. In rural EMS, we are normally going to transport that patient and at sometimes they are going to be in cardiac arrest and doing CPR in a moving vehicle. However, during testing processes, you should, if they give you this answer, you should stop the vehicle, perform CPR, and deploy the AED. That is the answer that you should choose, not what you would do in rural Minnesota. Just remember that you are in the largest city with every possible resource available when you're taking this test. So that's how you have to think about this. Cardiac arrest care for hypothermia and submersion injuries. First, you're going to attempt the defibrillation once in a hypothermic cardiac arrest patient. You're going to wait until the core temperature is at least 86 degrees Fahrenheit before attempting defibrillation again. Do not terminate resuscitation in the field for hypothermic patients. Remember, they're not dead until they're warm and dead. Treat a submersion injury patient in cardiac arrest the same as you would treat any other patient in cardiac arrest. You want to be aggressive with the airway management and rescue breathing. You also want to take precautions to make every defibrillation safe for you and your team in a water environment. Do not defibrillate a soaking wet patient. Dry their chest or move out of the wet environment. Remove medication patches to prevent any burning. Implants and surgeries. Defibrillation can be performed on a patient with an implanted device. You want to position the defibrillation pads on the patient's chest to avoid contact with that device. Some devices and surgical implants you may observe in the field could include a cardiac pacemaker, an implanted defibrillator, a ventricular assist device, or a cardiac bypass surgery. All right, let's do a quick chapter review. Cardiac arrest occurs when the pumping of the heart stops. This is commonly caused by lethal dysrhythmias, including ventricular fibrillation, ventricular tachycardia, asystole, and pulseless electrical activity. Cardiac arrest causes an immediate drop in coronary and cerebral perfusion pressure. Without immediate care, the cells of the heart and brain will die. Most cardiac arrest is sudden in nature, most commonly caused by an acute coronary syndrome. Some cardiac arrest is caused by asphyxia causes, especially in pediatric arrests. Cardiac arrest is recognized by unresponsiveness, apnea, and pulseless. To provide excellent care and the maximum chance of survival for patients in cardiac arrest, EMS agencies must strengthen their performances of the 5 elements of the chain of survival. First being recognition and activation of the emergency response system. Next, immediate high-quality CPR, rapid defibrillation, basic and advanced emergency medical services, and advanced life support and post-cardiac arrest. Stressful resuscitation is a product of teamwork and quality management. Things to remember. The most important element of cardiac arrest care is the administration of high-quality chest compressions. The American Heart Association's Chain of Survival describes the key elements necessary to maximize cardiac arrest patients' chance of survival. Remember that mechanical CPR devices provide automated chest compressions in cardiac arrest settings. AED provides early defibrillation in cardiac arrest patients with ventricular tachycardia and ventricular fibrillation. Post-cardiac arrest care is an essential element of the cardiac arrest care. Questions to consider. Describe how to clear a patient before administering a shock. Remember, you never want anybody touching the patient, either yourself or your partners, before shocking that patient. Some other questions to consider is to list 3 safety measures to keep in mind when you're using an AED. You want to list the steps in the application of an AED. I highly recommend knowing these and understanding them. Critical thinking. A 78-year-old male has been complaining of severe shortness of breath for 20 minutes prior to your arrival. When you arrive, you find the patient unconscious and not moving. What are your immediate priorities? As always, if you have any questions, please make sure to reach out to your instructor. Thank you and have a great day.